My two areas of research are colorectal cancer and cancer of unknown primary. So colorectal cancer, there's a lot that has been done on colorectal cancer already, and lots of work that is undergoing as we speak. So maybe in interest of time, let us focus on cancer of unknown primary, which is an intriguing entity in its own right, less researched, and I actually call it the road less traveled. Um, so cancer of unknown primary, the first question is what is it? And it's exactly what it says on the tin, really. So patients would present with an advanced stage 4 cancer with several secondaries in many places. But usually when a patient presents with a new cancer diagnosis, even if it's a stage 4, the scans will be able to tell you, a scan or a stool test or a clinical examination will be able to tell us where the cancer started from, which we call the primary. And this is about 96% of new cancer patient diagnosis. In about 3 to 4% of new cancer presentation, this is not the case, where there's clear evidence of secondaries and mostly really widespread secondaries, but there's no evidence of where the primary cancer started from. So that itself is very intriguing because, how do you focus the diagnostics? Who does a patient present to? Who takes ownership of the case? How do we design the most appropriate personalized oncology treatment? But in the nature of the diagnosis itself, the problem lies that patients, they're not aware, mostly patients or even healthcare professionals are not aware of this entity, although it's well recognized. And so there we deal with late presentations, late diagnosis, and that has a huge impact. So in a nutshell, it's bad biology. The pathway is completely fragmented, disrupted. It's bad outcomes, and really the 1-year survival rate of these patients is 20% or less, with 50% of the deaths, more than 50% of the deaths happening in the first 3 months of diagnosis, and that is appalling. And the focus of the research and my clinical work is to change that outcome. And for a long time, I had a pushback from well-meaning healthcare professionals, colleagues, peers, who said that, Sonali, what's the point? This is a poor prognostic group of patients. I mean, look at the survival figures. What can you do about them? That's whatever you do, the end outcome is really bad. And given that NHS resources are restricted, given that the funding and everything is so tied down, and we have to prioritize, should we not be looking at other areas to focus? Just for instance, colorectal cancer, for instance, breast, prostate, all the biggies, But my pushback was exactly on that point. And if it is a less researched area, if there's dearth of clinical trials, if the outcomes are so bad that we are not thinking about them, maybe we should flip the coin around and start thinking about this poor prognostic group. And maybe that is why we should be interested to turn around the outcomes and do things significantly better in terms of not just survival, it's about patient experience, it's about the patient journey. They have been always considered as an orphan group. There was no place for them to belong to. So they did not have any comprehensive workup. There was no oversight on who is doing what. In Wales now, and we take credit for being the first in UK of giving this group of patients their own unique place. I think my biggest achievement is that for a vulnerable group of cancer patients like the cancer of unknown primary, I've helped this group of patients find their place, find the recognition that they deserve. And in that, I have actually facilitated an accelerated rate of progress in clinical care, in research and development for these patients. I've got stacks of cards sitting on my windowsill in my office, and all my patients who, my clinical workload is about patients who have got complex cancers and advanced cancers. So even in my colorectal practice, there's the ones that come through to me are the ones who have stage 4 or locally advanced cancers. There's not a lot of happy stories, happy outcomes there. there's not a lot of curative treatment that I can offer to the patients. But things have changed in both cancer subsides, and we do a lot more for the patients. Some of these stories do turn out to be happy stories. So I do receive a lot of acknowledgement from the patients, but the most thing that touches my heart to the very core is when patients pass away. So there's no happy story there. Patient has passed away from cancer, but the next of kin, they have acknowledged more than once. They've acknowledged, how supportive, how empathetic the patient's consultant has been, and how important it was from their point of shared experience.